In this country, every year there is about 500,000 of suspicious thyroid nodule for which you need to do some type of examination. And in general, it's called a fine needle aspiration of the suspicious nodule. Then with this aspiration, you can perform a pathology assessment to determine if there is cancer or no cancer. And in some case, 20%, 30% of the case, the result is not clear. It's called indeterminate. So in that case, you need molecular testing to help you categorize, classify the nodule as malignant, because in general this nodule requires surgery, or benign, because in most cases, if not required, you want to avoid surgery. The first poster what we presented is a test called Diagnostics, and it's an analytical validation of this test. So it's a test based on next generation sequencing, and we identify different oncogenes and mutations that are associated with cancer. So the idea is that if you have an oncogenic mutation in the thyroid, it's more likely to be malignant and therefore will require a surgery. So this panel has been validated extensively, and that's what we presented in this poster. We have done accuracy study to show that not only we can detect mutation, but accurately, and precision study to show that it's reproducible. From the precision study and accuracy study, we observed 99.9% accuracy overall relative to another test that was already validated. So a very good agreement between two different methods. So the other poster was a research study where now we look at the combination of mutation detection, like with Diagnostics, with a new type of test that is called Thyroid. This combination testing has been developed specifically for the same application, detect thyroid cancer, but also to rule out cancer in benign nodule. That's the other part of the application. You want to identify cancer, rule in cancer, and rule out cancer in a benign nodule that does not require surgery. So the way it works is that by combining mutation testing with microRNA expression classifier, now you can not only identify nodule with a high predictive value, that's called positive predictive value, but you can also identify nodule with a high negative predictive value. And this poster more specifically was asking a question. Can we now add more mutation and try to improve the performance of this type of testing incrementally by adding more and more mutation? And what we found is that indeed, by adding more mutation to the current panel, like for Diagnostics, for example, we can add more and we increase the sensitivity. We can detect more malignant nodule. But there is a little problem, is that when you do that, you also lose specificity. Now you can start to detect mutation that have not been clinically validated in nodules that are benign. And that's not good, because you don't want to give up on specificity just to increase sensitivity. So you need to have a balance. There are commercial tests out there that have high sensitivity but low specificity, and they are very useful, but only to rule out cancer. What we want to do here for the very first time is be able to rule in and rule out. So what we have found and reported in this poster is that the best combination is to use a subset of validated mutation, like the one in Diagnostics, and to combine that with microRNA testing. And the both, again, give you both high sensitivity, high specificity, and therefore both the rule in and the rule out.